So OCD is Obsessive Compulsive Disorder. As the name suggests, it has two main components: obsessions, which are primarily driven by intrusive thoughts, and compulsions, which are usually the responses a person is coming up with to deal with the anxiety these intrusions are generating. So by nature, intrusive thoughts or obsessions are things which are happening inside the brain. They do not have to be only thoughts, although that is the most common manifestation of intrusion or obsessions. They can be feelings, they can be sensations, but by nature all of them would increase anxiety. This increase in anxiety or distress usually then drives compulsions. So it's a cycle. There is a phenomena which is increasing distress or discomfort, and then there is a phenomena which person or the brain is coming up with, which could take the form of compulsions or sometimes reassurance seeking or safety behaviors, avoidance, etc. All of these are going to reduce the distress. So this cycle, when it is happening together over and over again and causing interference in person's day-to-day activities, is considered a disorder, and we name it as Obsessive Compulsive Disorder. Because the most common form of intrusive thoughts are about contamination, that there is something in the environment. It could be a bug, it could be a chemical that is going to cause harm to the individual or to the near and dear ones, and there is this intense kind of reasoning process then that goes along to solve that problem of contamination. So that's a common. Around 40% of patients with OCD would have contamination related intrusive thoughts, and it's a common presentation. It could be about a specific bacteria, specific bug, or specific chemical, or it could be just a general feeling that something is not right, something is not clean enough. It can present in different forms. However, the common theme around it is that these feelings of contamination or thoughts about contamination would cause intense amount of anxiety, to the extent that the person is then forced to change their routines. They might have to incorporate quite a lot of washing rituals, hand washing most commonly, or they might have to spend a lot of time doing washing, bathing, cleaning, or using a lot of strong chemicals, bleach, or using a lot of safety behaviors like wearing very thick gloves to be able to touch things, to be able to do their day-to-day activities. Or if it is in its most severe form, it can also cause a threat to life, because patients would learn to avoid these contaminated areas like bathrooms by not drinking water, and that can cause kidney problems. So OCD can be classified into a few different forms, and traditionally it has been classified as contamination related OCD, then order and symmetry related OCD, wherein there is a lot of effort that goes into to make sure that things are following certain imaginary rules the brain is coming up with, or are symmetrical, and any amount of asymmetry in the environment can cause distress to the brain. Then there is something we call harm OCD in lay language, but it is more about protecting ourselves or others from harm, and that could be driven by a different form of intrusive thoughts. And previously we also classified hoarding disorder related thoughts as part of the OCD. So that category is no longer there, but traditionally hoarding was also a type of, considered as a type of obsessive compulsive disorder. And we can also look at morality or taboo thought driven OCD as another category. There is a particular circuit in the brain which we call which connects many important centers or stations in the brain, which is called corticostriatal thalamocortical circuit. It's a mouthful of a name. We refer to it as CSTC. This circuit, we know for last more than 20 years now that a part of it shows hyperactivation, and that's a kind of finding across all cultures, all countries. Wherever we looked at OCD brains, wherever we could study this circuit, we have found this to be a consistent finding. We also know that when OCD gets better, the hyperactivation that we see in particular part of the circuit gets down, so it becomes closer to the normal activity. It does not become normal, but it becomes closer to the normal activity. So science does have a fairly good understanding of what is kind of causing OCD. Now, why this hyperactivation happens is still an area we do not understand. There is a good body of evidence to consider that part of it is genetic, that we inherit the risk. Now, going back to the science of why this hyperactivation is happening, one of the scientists around 10-15 years ago asked the question whether this hyperactivation is happening because of OCD, or is this hyperactivation causing OCD. So, and they eventually did a very interesting experiment with the mice models of OCD and their animal models of OCD, wherein they conclusively proved that this hyperactivation is leading to OCD, not the other way around. So we have good evidence to support the fact that there is a circuit abnormality which is happening in the particular part of the brain, which is leading to these symptoms. However, we do not have the science to support why this is happening in the first place. So there are two forms of effective treatment for OCD, and one is exposure and response prevention, which is a form of behavioral treatment, which is now considered a treatment in the broader umbrella of cognitive behavioral therapy. But it predates cognitive behavioral therapy. It has roots from 1960s research and 1970 research. If we expose the brain to the situations which it finds triggering, which are leading to these cycles of intrusive thoughts and then compulsions, and then do not engage in the responses like compulsions or avoidance, etc., then the brain would learn that these are not the dangerous situations and produce a response called habituation. Now, habituation is a form of learning which happens by it cannot happen at a rapid scale like we see in learning by reading, learning by watching a video, or learning by sitting in a classroom. It has to happen by repetition, because we are targeting very kind of basic fundamental learning circuits in the brain. So it does take time to produce, and it's also a very difficult treatment to pursue, because initially what we are asking the person to do is to face exactly the same scenarios they are trying to avoid because of their fear-driven strategy which they have adopted so far for the OCD to thrive. The other form of treatment which is very effective, again it has roots in 1950 and 1960 research, is medication. One specific category of medication, which is serotonin reuptake inhibitors. It is based on the fact that one of the key finding in OCD consistently has been that in certain areas of the brain there is less serotonin, which is one of the 4 key neurotransmitters in the brain. There is less serotonin available, and if we boost the level of serotonin in that particular part of the brain, we see OCD symptoms improving. Now, this is different than the serotonin hypothesis we have in other conditions, and it is also more robustly replicated in many research studies over the last 50 years. We also know that when we use OCD related medication, and there are 7 medication that we use commonly, 6 of them are SSRIs, selective serotonin reuptake inhibitors, like fluoxetine or sertraline, which are commonly non-medication, and one is a tricyclic chemical which is called clomipramine. All of them are boosting serotonin in the circuit I was referring to earlier on, and improving OCD symptoms. If we look at the overall response rate with both medication and exposure treatment, these are amongst the highest response rate we get with treatment for any psychiatric disorder. So OCD, by availability of these treatments, is a very treatable condition. So the first bit of advice is that we have to start by making a distinction that we are not our brain. Our brain is misfiring in a particular circuit. That's what we see in signs of OCD, that part of the circuit is hyperactivated. It is then producing these intrusive phenomena which can manifest as thoughts. But if you look at other abnormalities in the same circuit, these intrusive phenomena can sometimes present as intrusive movements. We call them tics. When tics happens, we do not take responsibility for them because we see them as something different than us. However, when thoughts happen, intrusive thoughts or intrusive feelings, we end up taking responsibility for them. It is counterintuitive not to do so. So people are doing the right thing. However, it's important to understand that, because the moment we start taking responsibility for it, we start experiencing the associated emotions, which could be emotions of guilt, shame, danger. All these would then increase the probability of brain producing a fear response, which is going to create an uncomfortable situation for us. Over a period of time, this also leads to development of avoidance, that people learn to avoid certain situations wherein all these things, all these uncomfortable emotions are going to be more prominent. That can limit our function, that can limit the things we can do. So I've not come across any OCD patients who is actually not very capable in solving the problems. In fact, the people who are more capable of solving the problems usually are more affected by compulsions because they are putting in a lot of effort to deal with the intrusive thoughts. And so the first tip I give to any patient I come across is to make a distinction that this is a brain disorder, this is not you. You have to stop taking ownership for what your brain is doing.